Hello everyone, my name is Manoj Patel. I am the first year infectious disease pharmacy fellow here at Loma Linda University, and today I will be teaching you guys your central nervous system infections lecture. We'll go ahead and get started with a introduction on the central nervous system and the infections associated with it. We'll do a basic review of the central nervous system anatomy and physiology. We'll look at the epidemiology of these infections, how we can classify CNS infections. There are a lot of classifications that we'll look into, and then references for the guidelines and additional resources that are used in this presentation. So up first, the anatomy and physiology review. This may look pretty familiar for those of you who have taken anatomy and physiology. We have the central nervous system, commonly abbreviated as the CNS, which comprises of the brain, spinal cord, optic nerves, and the surrounding membranes. Now we refer to those surrounding membranes as the meninges. And the meninges comprises of three layers that essentially function to provide protection to the brain and the spinal cord. And those three layers are the dura mater, which is the outermost layer, the arachnoid, which is the middle layer, and the pia mater, which is the inner layer. Now, within the central nervous system, we have a special fluid called the cerebrospinal fluid, commonly abbreviated as CSF. CSF is an ultrafiltrate of plasma within the CNS ventricles and the subarachnoid spaces, and they kind of have similar functions to the blood in terms of the rest of the body. Now, blood is toxic to neuronal tissue, which is why it gets separated from the central nervous system, and we'll talk a little bit about how that separation occurs. But in terms of its functions, those functions are similar to the blood. So the CSF functions to provide nourishment, waste removal, as well as protection for the brain and spinal cord. Now, the CSF is really important to us clinically because it is an important diagnostic tool. We use it to diagnose many different CNS diseases, and that does include infections as well. And so below in this table, um, if we were to take a normal human being and take their CSF out, we'll talk a little bit about how we can obtain CSF from someone. But if we take it out under normal conditions, they should look like something this table provides. So its appearance should be clear and colorless. If you were to count the white blood cells within that fluid, it should account to less than 5. Differential, if you're not familiar what that is, but if you were to take the white blood cells and differentiate between them, you have all our different white blood cells, monocytes, lymphocytes, neutrophils, etc. If you were to do a differential of the white blood cells in a normal CSF analysis, you should have a majority of them being monocytes. The proteins in the CNS should be less than 50. We'll talk a little bit about why that is important. Just like the blood, the CSF also has glucose. This is how our neurons get energy, and the normal glucose range in a CSF fluid should be around 45 to 80. And then we can also do what's called a CSF to blood glucose ratio. So that is essentially taking the glucose within the cerebrospinal fluid and just dividing it by the serum glucose. We obtain a ratio. If we multiply that ratio by 100, we get our percentages. We'll look at that calculation a little bit later. But ultimately, we should have a CSF to blood glucose ratio of between 50 to 60% in a normal person. So I talked a little bit about why the blood is toxic to the brain, or that it is toxic to the brain, rather. And so the way our bodies separate the blood from the brain is by these natural barriers called the blood-brain barrier, as well as the blood-CSF barrier. And so ultimately these function as a natural barrier between the blood, brain, and CSF. And the blood-brain barrier is comprised of tightly conjoined capillary endothelial cells, whereas the blood-CSF barrier comprises of ependymal cells of the choroid plexus. You don't really need to know too much about the anatomy. Again, this is just a little bit of an A&P review, but it is important when we look at drugs and how they can penetrate into the CNS. We'll talk a little bit later about the pharmacokinetics of these agents, but if you do have a patient with a CNS infection, we'll talk about where that infection is. It's specifically like within the CNS, so it has to cross these barriers. And so that's kind of when the pharmacokinetics of a drug becomes important because we need to find a way for our drug to ultimately cross through these barriers and get into the CSF so that they can act on the infection. So let's talk about the epidemiology of CNS infections. We have community-acquired bacterial meningitis. So that is just anyone living out in the community and suddenly have bacterial meningitis, landing them in the hospital. In the US, we get about 4,100 annual cases, and that has been reported from 2003 to 2007. And then interestingly enough, there is something called the meningitis belt, which is located in sub-Saharan Africa, and that's characterized by seasonal and explosive epidemics where 350 million individuals become at risk for meningitis. There's also viral encephalitis, so looking at a more viral pathogen rather than bacterial, and we see its incidence peak with young and elderly patients. That will be important later in the lecture. And we normally see about 20,000 encephalitis-related hospitalizations per year, and it can cause about 1,400 deaths per year. Here are the general classifications I alluded to earlier. You are not responsible for memorizing the definitions for each of these classifications, um, but I present this to you because it's really important to understand the different distinctions. So looking up at meningitis first, which by definition is inflammation of the meninges in the brain and spinal cord. Now, meningitis is again just inflammation. So inflammation can be caused by a lot of things, not just microorganisms like viruses and bacteria. There are other causes of meningitis, and so it's always important to rule out, is this truly a infectious meningitis picture or something else? Um, Now you can differentiate meningitis between acute and chronic, where acute is a rapid onset of your clinical symptoms and signs. It can occur in someone from hours to days. Maybe you have a patient who is completely normal, and then in just a few hours, maybe overnight, they become extremely altered, fatigued, have fevers. That is what we would call an acute meningitis. Or it can be chronic, where you see these clinical signs and symptoms kind of persist for greater than 4 weeks. Encephalitis is an inflammatory process of the brain that is in association with clinical evidence of neurologic dysfunction. And so a lot of the times the definitions between encephalitis and meningitis get switched around and confused. And some clinicians you'll see will just combine the terms and call it meningioencephalitis. And so that just kind of describes, well, this person has meningioinflammation along with encephalitis. Um, they might not entirely be aware of the nuances of the two, so they'll just combine it together. Ventriculitis is inflammation of the ependymal lining of the cerebral ventricles. Myelitis is inflammation of the spinal cord. A brain abscess is where you have a pus-filled accumulation in the brain, and that's generally caused by a bacteria or fungus. And then you can also have subdural and epidural empyemas, which is a collection of pus in the subdural and epidural cavity, respectively. And there are still, unfortunately, more classifications. These are kind of the more important ones to know clinically when you go onto your rotations and become pharmacists, especially if you maybe work in like a health system or a hospital. So you have your community-acquired bacterial meningitis, and that is meningitis that is a result of bacterial invasion from the blood or direct extension from local infection, such as the pharynges. You can also have healthcare-associated ventriculitis and meningitis. This was formerly referred to as nosocomial meningitis, which is a subclass of bacterial meningitis that occurs in patients who are neurosurgical patients. So they have maybe some sort of CSF shunt and drain, and we'll look at what those look like later. And then we also have viral encephalitis, which, as the name suggests, encephalitis that's a result of a viral pathogen. Again, I'm not going to hold you responsible for memorizing these definitions, but it's important to be able to distinguish them as you go onto your rotations. Here are my go-to guidelines and additional resources. I will use the IDSA guidelines a lot, but unfortunately, as you might notice, these guidelines are extremely outdated and are due for renewal. So sometimes when you're in clinical practice and you refer to what's in the guidelines, it may not be always what's being done clinically. There are lots of new studies out available, new trials out that has kind of changed the practice, and so that leads to a lot of conflicting literature. I will, in the lecture, show you what those conflicting literature recommendations are, and you won't be held accountable for knowing these literature, this conflicting recommendations for the exam. I think that's just personally unfair. I'll make it pretty clear what you are and won't be responsible as we go through this lecture. And so that, with that being said, we will jump into our learning objectives. We do have 5 of them to go through. Our first learning objective that we'll focus on is to describe the pathophysiology, diagnosis, and clinical presentations of CNS infections. So again, remember how we differentiated the classification? So this is the pathophysiology of community-acquired bacterial meningitis. So we're thinking of our normal person living out in the community, normal healthy human person who acquires bacterial meningitis. Now, the pathophysiology for this is exactly unknown, but it is proposed as in 4 steps here. So we can have mucosal colonization and bacterial invasion of the CNS. So we all have bacteria living right on and in our body. I'm sure you've already learned this. And so in our mucuses, specifically our pharynges, we have mucosal colonization of just normal bacteria that live there and they belong there. However, they can invade into the CNS. And once they invade into the CNS, they will become an opportunistic infection, right? There's nothing else in there, and the CNS is what we call a sterile site, so bacteria and other microorganisms shouldn't belong in there. So they're going to take advantage and just start replicating in that subarachnoid space. And ultimately, that will result in meningeal inflammation, where we start to see our clinical signs and symptoms of meningitis. Meningeal inflammation will result in increased intracranial pressure, or ICP. If you take a critical care class or do a critical care rotation, you will understand just how important intracranial pressure are. But essentially what happens is if you increase intracranial pressure, and also as a result, you also have increased cerebral edema, that's going to compress onto the brain, right? Our skull is a limited space, and if you increase pressure in there, if you increase the inflammation in there and the fluids, that is going to directly damage the brain and cause neuronal damage and even death in a patient. And so I don't say this very lightheartedly, but with infectious diseases, we don't really see a lot of cases where they are medical emergencies, right? We don't have like patients going into cardiac arrest or a trauma patient coming in from an accident or something like that. But once someone does have a bacterial meningitis, we do not mess around. This is a medical infectious disease emergency, and we want to get treatment going stat. So The exact mechanism of bacterial invasion into the CNS is officially unknown, but it is thought to be due to continual exposure of a high bacterial inoculum. So maybe a patient has a lot of high bacterial burden, and one of those bacteria maybe went into the blood and then ultimately into the central nervous system. That's kind of the proposed mechanism here. And unfortunately, our host or immune defense in the subarachnoid space is inadequate to combat bacterial pathogens, and so the bacteria can just replicate freely within the CSF. And again, remember we looked at the CSF has a lot of good nourishment for our cells, and that's exactly what the bacteria wants too. So they're going to start using what's in our CSF for themselves and start replicating and cause an infection. Now, what we do know is that many bacteria that cause community-acquired bacterial meningitis are normal colonizers of the upper respiratory tract, right? So our upper respiratory tract, again, is where we have mucosal colonization of bacteria, and so it's theorized that these are the bacteria that are somehow getting into the brain, causing infection. And so when you know the source of an infection, you know what to empirically cover for. And we'll talk a little bit about what our empiric regimens look like later. All right, so that was community acquired bacterial meningitis. Now, how does that differentiate from a healthcare acquired bacterial meningitis? So when we use the term healthcare acquired bacterial meningitis, this is meningitis that's associated with a variety of invasive procedures or head trauma. So this is not your normal healthy human person living out in the community. This is someone who has maybe had head trauma, maybe from an accident, maybe some sort of underlying CNS dysfunction that requires them to have some sort of device. Some of the most common devices you'll see that can go into someone's CNS is something like a CSF shunt. We have a ventriculoperitoneal or a VP shunt, ventriculoarterial shunt, or a ventricular pleural shunt. And what these shunts do is basically in some patients, they have too much CSF. They produce too much CSF, and if you have too much CSF, you'll have too much intracranial pressure. And remember, too much intracranial pressure is bad. It can cause neuronal damage, it can cause death. And so one of the ways to kind of help shunt that CNS infection is by using these different kinds of shunts. Or we can just drain it by using an external ventricular drain or an EVD. And essentially, the difference between a drain and a shunt is that the shunt will direct the fluid into somewhere else in the body, um, whereas a drain will drain. Oh, sorry. And whereas a drain will drain the CSF outside of the body. Okay. Um, and so the suspected pathogens will differ when treating healthcare acquired bacterial meningitis versus the community acquired meningitis. And we'll look at what we need to empirically be treating for a little bit later when we jump into the treatment recommendations. And these are kind of the pictures of our drains and shunts. So as you can see with the EVD, this patient has a drain coming out of their CSF. And so CSF is literally coming out and collecting here. And this can actually help measure your intracranial pressure. And if you ever go into an ICU or especially a neuro ICU, you will see you will maybe have the opportunity to see how these work. Really fascinating. And then these are shunts. This is kind of more for, okay, I need to get my patient outside of the hospital. They're stable, but they're still producing too much CSF. What can I do? They will actually make these shunts and drain the CSF into maybe like your heart or maybe the peritoneum. And that's basically just a method to get the uh, CSF fluid out of your brain so it doesn't cause damage. But again, as you can see, if you put it in these sites, you also have bacteria living at these sites, and so you may see these patients having kind of like a reverse mechanism. These bacteria will migrate up towards the brain, and then this is where we start getting our healthcare associated CNS infections. All right, and then we have our viral encephalitis. So it's very similar to community-acquired bacterial meningitis. However, this time, instead of a bacteria, it's a virus that will invade the CNS hematogenously, where then again it will replicate and cause disease. Some viruses may enter the CNS via the nerve endings in a retrograde manner. These viruses include herpes simplex virus, rabies, and the herpes zoster virus. Um, the herpes simplex virus specifically is associated with calcification, especially in children. And then we also have an arbovirus encephalitis, which is associated with focal necrotic lesions. So what will a patient look like when they come in to the hospital with a meningitis? They're gonna really look similar to anyone else that comes in with a severe infection. You may see some variations between age, immune status, maybe the duration of illness, like was it a very acute onset versus a more chronic onset? And then you'll also see variations in causative pathogens. But the classic signs and symptoms we have this classic triad of meningitis symptoms, which includes fever, mucorigidity. Mucorigidity is basically neck stiffness, as well as altered mental status. Now, in clinical practice, a lot of times you might see a patient who has mucorigidity, neck stiffness. I mean, I get mucorigidity when I get out of bed. So it's always important to correlate the other signs and symptoms in the classic triad, especially in altered mental status, especially high fevers. Um, in addition to everything else down here, chills, nausea, vomiting, photophobia, severe headache, seizures, to kind of help suspect if this patient truly does have a bacterial meningitis. Because the last thing you want to do is look at someone and they say, yeah, my neck is a little stiff, and you start throwing a bunch of antibiotics and antivirals at them. Um, Altered mental status we see is more common in viral encephalitis. And then we'll also see these unique purpuric or petechial skin lesions. And that's classically has been associated with Neisseria meningitidis. We'll talk a little bit about that organism later. H. influenzae has also been associated with skin lesions as well. Furthermore, we also have what's called the Brudzinski and the Koenig sign. These will be done by the physician generally to kind of help further rule in if a patient has meningitis. First up is the Brudzinski sign on the left here, which if you have flexion of both hips and knees when the neck is passively flexed. And then we have the Koenig sign on the right here, which is resistance to full extension of the leg and knee when the hip is flexed. And so it's kind of used as a diagnostic tool, but it's really important to know that these tests are poorly sensitive and frequently absent in like in our pediatric patient population. So they're not, the most reliable, but kind of helpful diagnostic tools for the physician. But we also have our diagnostic tests, which are arguably way more important. I talked earlier in the lecture about how do we get CSF, and the way we do that is with a lumbar puncture. This is essential for diagnosis as we need to obtain our CSF to do a fluid analysis. We can send that CSF to the microlab so that they can culture it, so we can culture out an organism. And lastly, we can also uh, send the CSF for multiplex PCR, which is kind of a relatively newer technology where instead of having to wait for the culture to grow out into a specific organism, we can use this multiplex PCR, which can rapidly identify an organism without the need of having it grow. We also have neuroimaging techniques, so computed tomography or a CT scan or a magnetic resonance imaging or an MRI. They can kind of help detect inflammation in the brain, and so that can kind of you can use that to kind of correlate whether or not a patient truly does have meningitis. And then blood cultures are also strongly recommended for those that you suspect a bacterial CNS infection. And that's because that's kind of the mechanism of how the bacteria gets in the brain in the first place, right? It doesn't go straight from like your upper respiratory tract into your brain. It first has to get into the blood and then it may go to the brain. And furthermore, it's important to collect the blood cultures and the CSF if you can prior to the first dose of antibiotics, because the culture yield would decrease by 20% after a patient receives antibiotics. And if you don't grow out anything in your cultures, you don't know what to treat, and then your patient is stuck on maybe 2 or even 3 antibiotics. And again, extremely important, CNS infections are medical emergencies, and so diagnostic tests should not delay initiation of treatment. So next we will look at our CSF analysis. So after your patient has a lumbar puncture and they sent the patient's CSF sample to the lab, they will go ahead and analyze it. And so we looked earlier at what a normal CSF analysis should look like. Sorry, let me change the color here to make it differentiate a little bit better. Um, so again, you should be able to know that this looks like a normal CSF, right? Um, less than 5 white blood cells. The differential will have more monocytes presence, proteins less than 40. We have good amount of glucose, 40 to 80, and our CSF to blood glucose ratio is 50 to 60. This is good. This is what we want to see in a patient. However, if our patient has a bacterial meningitis, the picture is going to look a little bit different. We're going to see way more white blood cells. And that makes sense, right? Our white blood cells are what fights infections. So, of course, we're going to see an increase in white blood cells. Um, our differentials are going to change. Neutrophils are the types of white blood cells that combat bacterial infections. So we expect to see that differential shift towards a more neutrophil dominant presentation. We will, as a result of an immune response, we will also see elevated proteins. And remember how I talked about the CSF is a very nutritious fluid for the bacteria? They're going to eat up all that glucose and deprive the neurons of getting those glucose, which is resulting in neuronal death. So we'll see our CSF glucose look a little bit on the lower side. And then as a result, if we reduce this the CSF glucose, then our CSF to blood glucose ratio is also going to be decreased. So if you kind of think about why, if you kind of look at these and like, I don't understand it, like why are these moving? Just think the bacteria is now in our CSF fluid and it's basically using it up. So it's using our nutrients, our glucose, and our immune response is trying to act against it. So increased white blood cells, neutrophils, elevated proteins. Now the picture is different with bacteria. Well, generally, will not expect as much white blood cells, so 50 to 1,000. Our differential will be a more lymphocyte looking presentation. Um, we will see mild elevation in proteins and viruses, right? They don't use glucose. They instead infect the cell. So we're going to see more of normal glucose. They're not going to eat the glucose and therefore a normal CSF to blood glucose ratio. So for the exam, you do not need to memorize what these values have to be. I will not hold you accountable for that. But you should know how these uh, different variables will differentiate when you get a CSF analysis. So if you get a patient with bacterial meningitis, or you don't know it's bacterial meningitis, and you just get the CSF result, you should know that if there's low glucose, that it is bacterial meningitis. And then the formula to calculate CSF to blood glucose ratio is down here. Very simple. All you do is take the CSF glucose, you divide it by the serum glucose and multiply it by 100 and you'll get your percentage. All right, cultures and PCR. So we talked a little earlier about the importance of getting cultures. CSF cultures are considered gold standard. They will allow a gram stain of the organism, so letting us know whether it's a gram positive or a gram negative infection. And then we'll also get finalized species and sensitivities, which is going to be extremely important for us when we decide what regimen we're going to recommend to the provider for the patient. The downsides of a CSF is it generally requires a lumbar puncture. If a patient already has some sort of drain or shunt, then they can go in and do a tap and remove the CSF. But in your normal person, they're going to need a lumbar puncture to extract that cerebrospinal fluid. And the finalization of cultures may take days. Bacteria take their time growing on media in the microlab. So you may not get your final species and sensitivities until 2 to even 4 days later. Now we do have the multiplex PCR, which is a rapid diagnostic tool, which also uses CSF, but it simultaneously and will rapidly detect organisms within an hour. So it's really useful if you get a patient that comes into the ED and you're thinking, yes, it's meningitis, get a lumbar puncture as soon as possible and send your samples down to the microlab so they can start culturing, but also run a PCR test on it because you may get an organism. And once you get an organism, you can tailor your empiric therapy down. And that optimizes the patient's treatment sooner, so increasing hospital outcomes, especially and it's especially useful when cultures are negative because now you kind of have two methods of detecting an organism. You're not just relying on it to grow on a culture, but you also have a PCR test that can maybe identify the organism. So maybe if your PCR is positive and your culture is negative, at least you have something to go off of. But the downside of a PCR is it won't detect all potential pathogens. It's limited into what it can detect. And a PCR test will only identify the organism. It will not report susceptibilities. All right, so for our next learning objective, we will look at the risk factors and common pathogens associated with bacterial meningitis and viral encephalitis. So here are the risk factors for a patient with bacterial meningitis or any kind of meningitis. Number one is lack of vaccinations. We do have vaccines available against some of the causative pathogens of meningitis, so it's extremely important to be vaccinated against those organisms. Patients who are immunocompromised, of course, are going to have a weakened immune system, so they're more likely to get infected. The same goes for patients with asplenia, having a weakened immune system. A patient who has had recent dental procedures, if you think about the upper respiratory tract, that can kind of include the oral flora, and so we can maybe see um, some of the pathogens that live normally in our oral flora translocate into the brain and cause infection. Patients who have endocarditis will have a very high bacterial inoculum by default. And so especially if they're untreated, that bacteria can easily get into their central nervous system. Consumption of unpasteurized dairy products, having a central venous catheter. And then when you look at your more healthcare associated patients, the biggest risk factors are going to be having some sort of head trauma, neurosurgery, or one of those CNS devices we looked at earlier. All right, so these are our most common bacterial pathogens when we're looking at a community-acquired bacterial meningitis. And so this chart is divided by gram-positives and gram-negative organisms. So it's also differentiated by age. So when we look at a patient who we think has bacterial meningitis, their age actually plays an important factor because depending on where they are in life, that can kind of help you decide what sort of empiric regimen you need because we have seen these bacteria be more commonly associated in certain age groups. So we'll start with the first age tier here, so less than 1 month. For patients who are less than 1 month old, the gram-positive organisms that we are most likely going to suspect will be Listeria and Strep A galactiae. When looking at gram-negative pathogens for these patients, we are generally going to think of our gram-negative enterics, which our gram-negative enterics are down here, E. coli, Klebsiella, or Enterobacter species. If a patient is 1 to 23 months old, then the spectrum shifts a little bit. The gram-positive organisms we think of are Streptococcus pneumoniae as well as Streptococcus agalactiae, but no Listeria. Um, and then the gram-negatives we tend to look at would be Haemophilus influenzae as well as Neisseria meningitidis. Now, most of your patients that you'll probably see in a general adult hospital are going to fit the next two age categories, 20 to 50 and greater than 50. So if we look at the 20 to 50 age range, we generally think of strep pneumoniae for these patients. Um, and for gram negatives, we think of Neisseria meningitidis. If the patient is greater than 50 years, then we think of Listeria monocytogenes. So Listeria comes back, and we still consider strep pneumo. For gram negatives, we can see that the gram negative enterics come back, and Neisseria meningitidis remains. Always important to know that strep pneumoniae is by far the leading cause of community-acquired bacterial meningitis in the United States. Again, community-acquired, so not our more complicated patients with those CNS devices. All right, so we just looked at our community-associated bacterial pathogens. So what about our healthcare-associated infections? So this is going to shift entirely. When we look at gram-positives with our healthcare-associated infections, we think of coagulase-negative Staphylococcus species. Um, we also think of Staphylococcus aureus. Um, so we have methicillin-susceptible Staph aureus and methicillin-resistant Staph aureus, so MSSA or MRSA. And then we also have Cutibacterium acnes. These are kind of our more common gram-positive infections that we'll see with our healthcare-associated meningitis. And then with our gram-negatives, we will see E. coli, Enterobacter species, Klebsiella aerogenes, Citrobacter species, as well as Pseudomonas aeruginosa. So it's extremely important to be able to differentiate these pathogens. From a normal community-acquired bacterial meningitis to a healthcare-associated bacterial meningitis. Because if you know what the pathogen is most likely going to be, then that is going to determine what your empiric therapy is. And then we'll finally look at our most common viral pathogens. So our more common viral pathogens are going to be enterovirus, herpes virus, and arbovirus. Herpes is kind of one that I will hold you more responsible for the purposes of this class. And then we have our more or less common ones, which includes all of the above. I won't name each of them, but the one I want you to pay attention to for the purposes of this lecture will be varicella zoster virus. Alrighty, so let's jump into our next learning objective, which is to recommend an appropriate therapeutic plan for a patient that presents with a CNS infection given a patient case. All right, this is going to be an extremely important slide to remember for the exam. So again, I differentiated this table based on the age groups as well as the most likely suspected pathogens that we want to empirically cover for. And then here is our empiric therapy. So this is what as we as pharmacists will come in for our recommendations. The providers will make the diagnosis and then they will often look to us and ask us, well, what sort of antibiotics do we need to get started for this patient with a suspected bacterial meningitis? So if our patient, again, is in that less than 1 month age group and these are the organisms we're going to want to cover for, our empiric therapy will comprise of either amoxicillin plus cefotaxime or ampicillin or plus an aminoglycoside. This will provide adequate coverage for the organisms. And then once we start getting culture results or maybe PCR results, then we can de-escalate and we'll talk about definitive therapy later. Something important to note with these patients, they're less than 1 month, so the cephalosporin that will be used is cefotaxime. We do not use ceftriaxone in these patients. For our next age group, 1 to 23 months, again, these are the organisms we're going to empirically cover for. And so you'll notice that our empiric therapy is going to change a little bit. Since we lose the listeria and these suspected pathogens, we do not need to start ampicillin in these patients. However, since we gain Streptococcus pneumoniae, we do need to add vancomycin, and I'll explain a little bit as to why when we look at definitive therapy. And then we'll retain a third generation cephalosporin. In this case, we can use ceftriaxone or cefotaxime. And the same goes for the next age group, 20 to 50. We have the same empiric regimen. Then if our patient becomes greater than 50 years of age, Listeria comes back as a suspected pathogen. Therefore, we will need to bring ampicillin back. So our empiric regimen will comprise of 3 antibiotics, vancomycin, a third gen cephalosporin, plus that ampicillin. Um, so again, an extremely important slide that you should know for the exam. All right, so we just looked at our empiric therapy. So now let's look at definitive therapy. So this becomes important when we actually do get our final culture and susceptibilities from the microlab. We have identified an organism, we have susceptibilities. Now we can say, hey, we can start de-escalating our antibiotics into a preferred regimen. Um, so first, let's look at Streptococcus pneumoniae, a gram-positive, which is why it's purple. And this is kind of why I alluded to vancomycin being important. For most strep infections outside of the CNS, we generally will not start vancomycin. However, when we have a patient with a CNS infection, Streptococcus pneumoniae does have a chance to be resistant to penicillin as well as a cephalosporin. And so when this happens, and the MIC is high, vancomycin becomes an agent of choice. And so we don't mess around with CNS infections. We will empirically start as if these pathogens are very resistant to vanc. Once we, or not, sorry, not resistant to vanc, but has high MICs to penicillin or cephalosporin. Once we can definitively say, based on the microsusceptibility report, that the MICs are not as high, then we can peel off the vanc. So let's say we get Streptococcus pneumoniae and we get we get a susceptibility report and the penicillin MIC is less than 0.1, then we can de-escalate all those empiric antibiotics to just penicillin or ampicillin alone. That should totally be fine. Um, If we get an MIC of 0.1 to 1 for penicillin, then we will keep a third generation cephalosporin, so ceftriaxone and cefotaxime. However, if that penicillin MIC is greater than or equal to 2, that is where we want to keep the VANC and continue with the third gen cephalosporin. The same goes for cefotaxime or ceftriaxone MIC of greater than or equal to 1. We will continue with vancomycin as well as the third gen cephalosporin. Extremely important to know this. For Neisseria meningitidis, if we have a penicillin MIC of less than 0.1, then penicillin G or ampicillin will be our preferred agent. However, if the MIC is 0.1 to 1, then we will use a third gen cephalosporin. For Listeria or Strep A. galactiae, ampicillin or penicillin G will be just fine. And then for Haemophilus influenzae, we test for beta-lactamase, so presence of beta-lactamase in the lab. If there are no beta-lactamase or it results as beta-lactamase negative, ampicillin becomes our agent of choice. If beta-lactamase is positive, then a third gen cephalosporin is our agent of choice. So really important to know this slide as well for definitive therapy, not just for the exam, but as well as in clinical practice, because if you are working in a hospital or you are rounding with the team, and these susceptibility results come back, they will look at you and want you to interpret it and provide a definitive therapy recommendation. So now that we looked at our community-acquired meningitis pathogens, let's shift gears and look at our healthcare-associated meningitis pathogens. So again, here are our gram-positive, so coag-negative staph, Staph aureus, and Cutibacterium acnes. Vancomycin should adequately cover all of these organisms. In addition to vancomycin for empiric therapy, we will add an anti-Pseudomonas beta-lactam. So our cephalosporins will generally cover E. coli, Enterobacter species, Klebsiella aerogenes, and Citrobacter. However, remember, Pseudomonas becomes a suspected pathogen in our healthcare-associated meningitis, and we will want to cover for this organism, and we do that by using either ceftazidime, cefepime, or even meropenem. If your patient has a true beta-lactam allergy, then alternative agents can be aztreonam or ciprofloxacin. So again, empirically covered for both gram-positive and gram-negative organisms in the healthcare associated meningitis patients. So VANC plus an anti-Pseudomonas beta-lactam. You'll notice that we are missing an anti-Pseudomonas beta-lactam in this chart. That is Zosyn, piperacillin, tazobactam. We'll talk a little bit about why this is not in our empiric regimen when we look at the pharmacokinetics of the agents. So once our cultures result and we have our final susceptibilities for identification and susceptibilities for our patient, then we can shift gears towards recommending a preferred definitive therapy for these patients. So for our MSSA pathogen, we will generally resort to nafcillin or oxacillin. The same goes for MSSE. Cefazolin historically was not recommended. We'll talk a little bit about why later. But however, in recent literature, I can now be recommended. So given that there are mixed recommendations, I will not hold you accountable for knowing that cefazolin may be a preferred definitive therapy for patients. If a patient results with MRSA or MRSE, then we will use vancomycin plus rifampin if they have some sort of retained hardware. So maybe they're a very complex neurosurgical patient. They have some sort of like hardware in their CNS. These organisms can get in there, and so to optimize their therapy, we will use something like rifampin. For patients that has an MRSA with a vancomycin MIC of greater than 1, we worry that we can't overcome the infection with vancomycin alone. So we will have to shift gears and use something like linezolid, daptomycin, or Bactrim even. For Chitobacterium acnes, we will use penicillin G. For gram-negatives, if we have any ceftriaxone susceptible gram-negative rods, we can use ceftriaxone. However, we do not use piperacillin, tazobactam, or Zosyn. And the reason why, and we'll talk a little bit about this later, is because this particular agent, if you look at its chemical structure, it's extremely bulky. And bulky agents like Zosyn will not cross the blood-brain barrier. And it doesn't matter if the organism is susceptible to Zosyn, if the agent is not going to get to the site of infection, it is not going to adequately treat the infection. So for that reason, MIC alone for any infection is not an indicator of if something is susceptible, then this agent will work. We always have to think about the agent pharmacokinetically. Will that agent get to the site of infection? Because it won't matter how susceptible the organism is to it. If the agent is not going to get to the site of infection, it's not going to be of any use for us. For Pseudomonas aeruginosa infection, we use ceftazidime, cefepime, or meropenem. For an ESBL gram-negative rod, meropenem. And then for a carbapenem-resistant Enterobacteriaceae, or CRE, I hope no one will ever see this growing in someone's CSF cultures. But if you do, colistin or polymyxin B will be the agents of choice here. So now that we know what antibiotics we should be using for our patients, it's important to know that these antibiotics, again, with that blood-brain barrier, this site being a notoriously hard space to get to for antibiotics, our dosing is going to look a little bit different than traditional infections. And so this table essentially goes through all the dosings of the agents we discussed, and you'll kind of notice that these dosings are going to be way more aggressive than you'll normally see. For example, ceftriaxone, usually we will do 1 to 2 grams every 24 hours. However, for CNS infections, it has to be dosed Q12 hours. So if you are working and you are verifying orders in a hospital and you come across an antibiotic with a CNS infection indication, please, please, please double check and make sure that the dose that they are ordering is correct. Because a lot of times physicians may default to just the standard dosing without knowing that you need more aggressive dosings for these agents to get into the CNS. And if you verify that order and maybe like 2 grams Q24 hours, you're potentially not treating the patient's CNS infection, which again can kill the patient. So it's our duty as pharmacists to make sure that CNS dosings are appropriate for patients when they are treating for a CNS infection. And vancomycin as well will be more aggressive. I'm sure you'll talk a little bit about this more in your PK lectures, but we use a higher trough goal or a higher AUC to MIC. I have both levels here because depending on what institution you are, they may still use trough goals. So you would use a higher trough goal of 15 to 20, but the AUC to MIC goal will remain the same in general, 400 to 600. For the exam, you do not need to know dosing or the trough or a AUC to MIC goal. But please, in practice, if you ever verify these orders, always, always, always double check the dosing for everything, not just antibiotics, but any medication. But especially when you have a patient with a severe CNS infection, please double check the antibiotic dosing. And then we also have our selected treatment durations for organisms. So if you're treating someone with Haemophilus influenzae or Neisseria meningitidis, we can generally get away with 7 to 10 days of therapy. For strep pneumo, 10 to 14 days. Strep agalactiae, 14 to 21 days. And MSSA or MRSA infection will treat for 14 to 21 days. For Pseudomonas, we'll treat for 21 days, and then for Listeria, we will treat for more than 21 days. These durations are kind of general recommendations. You'll generally have an ID specialist on board with any CNS infections in the hospital. And so kind of determining based on the patient's clinical presentation, like are they improving, they may have different durations in mind. And of course, newer data may change this as well. But for the purposes of this lecture, I am not expecting you to know the duration of therapy for the exam. So you will not need to know, for example, I won't ask you, how long do you treat Streptococcus pneumoniae CNS infections? You won't need to know that you have to treat it for 10 to 14 days. So we talked about cefazolin earlier and why it was a little bit controversial or has mixed recommendations. So cefazolin is a first generation cephalospore and it has traditionally been avoided due to concerns for inadequate CNS penetration. However, that's based on very old data. There's newer data now that suggests cefazolin may actually penetrate into the CNS when it gets pharmacokinetically optimized. So remember, we looked at those dosings, and so when we have a more aggressive dosings, we can rely on certain antibiotics we can rely on to cross the blood-brain barrier and penetrate well into the CNS. And so with that being said, we will use a more aggressive cefazolin dosing. So 2 grams IV every 6 hours, or even as a continuous infusion of 8 to 10 grams daily. So now that the recommendation is shifting. Cefazolin is now a reasonable option for the treatment of CNS infections with susceptible pathogens. Depending on where you work and who you work with, people may be amenable to this option or may just use the old reliable oxacillin. Um, it just kind of depends. And it's currently not implemented in the IDSA guidelines, but again, the guidelines are extremely old. So given that there's conflicting literature recommendations, I will not hold you accountable for knowing anything about cefazolin for this portion of the exam. So there's also dexamethasone, which is a steroid, and this agent actually has a unique role in CNS infections. Um, So the mechanism again, or the pathophysiology of meningitis, we have subarachnoid-based inflammation during the bacterial meningitis phase. And that inflammation has specifically been shown to increase morbidity as well as mortality. If you reduce the inflammation with a steroid like dexamethasone, it may be effective in decreasing the many of the pathophysiological consequences we see with meningitis. That increased cerebral edema, so swelling, increased intracranial pressure that can cause damage, neuronal injury, and death. And so overall, dexamethasone has very mixed evidence to support its use, but it is recommended per the IDSA 2004 bacterial meningitis guidelines as adjunctive therapy. So you will actually use dexamethasone with your empiric antibiotics. Study has shown that this benefit is most prominent when you're specifically treating Streptococcus pneumoniae meningitis, and so since this is the most common organism in our community bacterial meningitis, we will empirically utilize dexamethasone until the organism is identified to not be strep pneumo. So let's say you have a patient that comes in, kind of like a community bacterial meningitis picture, you get their CSF, and you're going to start empiric antibiotics. Please don't forget that dexamethasone should be administered with the first dose of antibiotics 10 to 20 minutes before, or at least with the first dose of antimicrobial therapy. Um, this will kind of help optimize the patient's care, and if it does end up to be strep pneumo, then that's good. If you find that it is not strep pneumo, then you can take off the dexamethasone. But this is a common agent that providers will tend to forget, but just remember that this is a common adjunctive therapy for the treatment of CNS infections. And for viral encephalitis, if you suspect a patient that has viral encephalitis, you will generally initiate acyclovir. That will be initiated in all patients that a physician is suspecting encephalitis in. And the dosing is here in this table below. Acyclovir 10 mg per kg based on ideal body weight. We use ideal body weight to reduce toxicities, and we'll give that as an IV every 8 hours for 14 to 21 days. Um, and Specifically, if we find out that a pathogen is herpes simplex virus or varicella zoster virus, then acyclovir becomes our drug of choice. We'll definitely want to keep a closer eye on this drug. Renal monitoring, getting a BMP, so looking at creatinine, BUN, as well as the patient's urine output. We'll give this agent with fluids as well to decrease risk of nephrotoxicity. And then we'll also get complete blood cells when available. There's also CMV, cytomegalovirus. You do not need to know this for the exam. I just included this in here in case you ever do encounter a patient with it. Ganciclovir becomes your agent of choice. But for the purposes of this exam, know that acyclovir is your empiric agent of choice for all patients suspected with encephalitis, and it is the agent of choice for a patient with HSV or VZV. So some key takeaways when we're treating CNS infections. Antibiotics should not be delayed due to LP or imaging. Let's say you have a patient that comes in and the provider is like, oh, we're not going to be able to get an LP for 4 hours, so we won't start any antibiotics because we want to be able to have a high culture yield. That is wrong. Antibiotics need to be initiated immediately and should not be delayed due to an LP or maybe a patient going to get a CT scan of their head. CNS infections are one of the few infections that is considered an ID emergency, and mortality has been shown to increase if treatment is delayed. So always advocate for your patient that antibiotics should not be delayed in patients where you're suspecting CNS infections. Always remember that the empiric therapy should be tailored based on the age range. That will show you what sort of pathogens we are going to cover for empirically. And then don't forget to add viral coverage as well for patients where you're suspecting viral encephalitis. Again, the signs and symptoms of viral encephalitis and bacterial meningitis are very similar. So most patients are going to also be getting an antiviral, but a lot of providers may end up forgetting. They may be too bogged up on, oh, let me make sure I get the right antibiotics in the right doses, that they completely forget the antiviral. So always remember that. As pharmacists, we need to pay special attention to CNS antibiotic selection and dosing. Remember again, these antibiotics require a more aggressive dosing regimen. So if you ever verify an order where CNS infection is the indication, always, always, always make sure that they are using the right dose. And then PK is important too. If a provider tries to prescribe Zosyn, tell them, hey, this actually won't even get into the brain, so you will not be treating the infection. And then, of course, the PCR test, not every provider will know that the PCR test exists. So if you do work at an institution where they have this test, always let your provider know that they should send a PCR test because that can reduce time to identification of the organism and help de-escalate your therapy or make sure, or maybe even escalate therapy if needed. But at the end of the day, only a culture result will give us the final susceptibilities needed to tailor our final antibiotic regimen. All right, back to our learning objectives. Number 4, we will summarize the pharmacological and pharmacokinetic profiles of the antimicrobial agents used in CNS infections. So this chart will go through the different antibiotics and agents that we traditionally use for CNS infections and will tell us if it will get to the site of infection or not. Like if it has good CSF penetration versus that it won't receive any therapeutic levels in the CSF. So this is extremely important to remember for us as pharmacists because providers will look to us and ask, hey, I want to use maybe linezolid for this patient. Will it get to the brain? And we will be responsible for knowing that. So here on the left, we have agents that have great CSF penetration. In the middle, we have agents that will have therapeutic levels in CSF when the meninges is inflamed. So it's kind of an interesting mechanism, and I won't go too in detail with it because it's more of an advanced topic. But when we have bacterial meningitis, when we have the inflammation of the meninges, that can actually kind of work for us and kind of help some of these antibiotics get in. Um, However, there are some important caveats to remember. And so the big one I want you to remember is Zosyn. You will see a lot of providers try to prescribe Zosyn for a CNS infection. However, you may not achieve therapeutic levels, especially in organisms that have a higher MIC to Zosyn, such as Pseudomonas. And then Tazobactam as well, the part that, it restores some of piperazolline's activity against some of the organisms may not even penetrate the blood-brain barrier. So just avoid piperacillin tazobactam for CNS infections in general. And then on the right here, we have agents that will have no therapeutic levels in the CSF whatsoever. Um, so aminoglycosides, amphotericin B, some of these others. So again, please know Zosyn. So some key points to remember, beta-lactams have poor CNS penetration. However, this can be counteracted by using more aggressive dosing and optimizing PK properties, such as using an extended infusion or a continuous infusion even. The inflamed meninges can play a role in the drug penetration into the CNS, and dexamethasone is an adjunctive agent used in the treatment of bacterial meningitis. It can immunomodulate the inflammatory response and has been shown to have improved outcomes in certain pathogens that are causing a CNS infection. All right, our last objective is going to choose an appropriate vaccine for the prevention of CNS infections given a patient case. So, as I talked about earlier in this lecture, we do have vaccines available, and the lack of vaccines is a risk factor for meningitis infections. So, one of the things we can do and recommend is making sure our patients are up to date on their vaccines. They have been shown to decrease incidence of meningitis cases. And then also having vaccine history on your patient in general can help rule out and rule in certain pathogens. So for example, these are the vaccines that we have available, strep pneumo. If your patient has had a pneumonia vaccine, then that can kind of help you rule out pneumonia. Is it always done in practice? No. Unfortunately, I don't think I've ever worked in an institution where he's a provider or even a pharmacist for that matter has looked and checked, hey, this patient has a strep pneumo vaccine. We don't need to empirically treat for strep pneumo. I think you'll probably get a lot of pushback if I'm being honest, and they'll still recommend all the antibiotics until they know what's growing, and that's perfectly reasonable in my opinion. Again, we don't mess around with CNS infections. I am all for, having empiric antibiotics, um, all of them available to us because at the end of the day, if the patient has a bacteria in their brain, we want to be aggressive with their treatment. Other pathogens that have vaccines are Neisseria meningitidis and Haemophilus influenzae type B. So first up, we'll look at the strep pneumoniae vaccine. This was first introduced in 2000, and then they did a lot of data and studies in here, and they found that when they introduced the vaccines in 2000 and 2010, it has resulted in declining strep pneumomeningitis, but it still remains as the leading cause of community-acquired bacterial meningitis in patients who are greater than 2 months of age. A majority of deaths has actually been seen in our elderly patients or those with an underlying medical condition. And so the vaccines we have available for Streptococcus pneumoniae includes our pneumococcal conjugate vaccines, or PCVs, PCV15, PCV20, and PCV21. We also have our pneumococcal polysaccharide vaccine, or PPSV23. Our next organism that we have a vaccine for is Neisseria meningitidis. Um, This is another leading cause of meningitis as well as sepsis in children and young adults in the US. And there are 5 serotypes of this bacteria: A, B, C, W135, and Y. And when patients have these infections, mortality has been described to be anywhere between 10 to 13% within 24 to 48 hours of symptom onset. And so immunization is recommended for our high-risk populations. So patients who have had an exposure to the infection, maybe there's an uncontrolled outbreak somewhere. If you're traveling to an area with an epidemic or hyperendemic meningococcal disease, or patients with a terminal complement component deficiency or asplenia. And so here are the vaccines that we kind of have available for this organism. We have the MEN ACWY conjugate vaccines, and so they cover those serogroups A, C, W135, and Y. And this is recommended for adolescents aged 11 to 12 years, and they'll get a second dose as well at 16 years of age. And then you'll also have a 5-year interval reimmunization for high-risk individuals. So we have 2 agents, Menactra and Menveo. So pretty easy to remember, right? They start with MEN for meningitis. So Menactra and Menveo. Menactra is for patients 9 months old to 55 years of age, and Menveo is for 2 months old and to 55 years of age. We also have MenB vaccine, which covers the B serogroup of Neisseria meningitidis. Um, and this is recommended for individuals who are at risk for invasive meningococcal disease. And so it can be considered in adolescents and young adults through a shared clinical decision making. Um, these vaccines include Trumenba and Bexsero. Trumenba is kind of easier to remember, the MEN again, and then B, so MenB vaccine. Bexsero, I mean, I guess the best way to memorize this one is serogroup B, right? So it covers serogroup B of meningitis. Um, Trumenba is a 2 or 3 dose series given at 0, 6, or 0, 2, and 6 months. And then Bexsero is a 2 dose series, at least 1 month apart. And lastly, we have Haemophilus influenza type B, or the HIB vaccine. Prior to 1995, HIB was responsible for many cases of serious illnesses, including meningitis. However, these cases have declined by greater than 99% since the introduction of its vaccine. So yay, it worked. And so the HIB conjugate vaccine is still indicated for routine use in all infants and children less than 5 years of age. And so the 2 vaccines that are currently available are Pentaso and Vaxilis. And that is the end of the lecture. Here are all the references that has been used. So if you have any questions, please relay them to Dr. F, and maybe Dr. F can relay them to me, and I can help answer or clarify any confusion. And I will look forward to seeing all of you all in class. So thank you.